Okay, great. All right. Thank you so much and welcome to the show, Kelsey. I really appreciate you being on.
Thank you so much for having me. This podcast has been a great source of education and connection for me. So I'm really happy to be here. Thank you.
Oh, thanks. Oh, I appreciate it. So let's just start at the beginning, just so everybody, we're all coming from the same understanding of exactly what is a holistic occupational therapist and how do you specifically work with kids?
Um, so holistic to me is kind of a buzzword, and I wasn't sure about using it in my branding and my business name and all of those things. But I think it's important to understand that I'm not just looking at one piece of a child. I'm looking at the family dynamic. I'm looking at the environment that they're in. I'm looking at their nutrition. I'm looking at their gross motor, obviously. I'm looking at so many different pieces,
Mhm.
and having the ability to zoom out from maybe the problem that is presented to me and prompting evaluation or something like that, and being able to zoom out and really get a good perspective on what's going on with this child. And that's what holistic means to me. I want to look at all of the different parts of somebody's life to be able to help pinpoint what needs to be worked on, but also maybe like, oh, maybe we need to have some more focus on this area first so we can have better access to the thing that we are here for, but we won't be able to get there just yet. It
Okay.
just depends.
And what kind of things exactly do parents, what kind of issues do they come to you with?
So most of the time people come to me with oral motor dysfunction, feeding issues in infants, open mouth breathing in infants and older kiddos, a lot of just general feeding challenges and nervous system regulation difficulties. Those are the big things that I see.
Okay, got it. I was going to say I assume, but I really don't want to do this. So is this it's definitely not a one and done, but is this something that happens over the course of months, or is this something that can be years working with the child depending on the case?
That's a great question. So I try to have minimal contact, which is kind of counterintuitive because I really want to have ongoing communication with parents, but I want our time together to be as efficient as possible for them because I know that time, finances, just bandwidth are of a concern for everybody involved.
Okay.
So usually when I see a baby, I kind of have an average of somewhere between 6 and 12 sessions, depending on why they're seeing me, the age of the child, all of those things. So there's a little bit of that upfront commitment. And then a
Mhm.
lot of times I'll have families continue with monthly check-ins or quarterly check-ins. And as of now, I have a lot of babies toddlers that I saw as babies that are circling back, and we're kind of revisiting some things that have evolved over the past year or two. So it's an ongoing relationship for sure.
Got it. And is it something that you see kind of if there's one child in a family, you'll end up working with multiple, or
Yes.
does it just vary? Okay.
So a lot of times I'll get the second baby. People haven't heard about me until they have that second baby because
Ah,
they're not quote unquote in the know. They don't have all of the doors open to them yet. They kind of
right.
did the traditional, hospital birth and hospital lactation visit and had their feeding journey from there. And then the second time they have a better idea of what they want their feeding journey to look like. So they're really trying to establish a team, and then they kind of find their way to me for that second. And it's a little backwards sometimes, but I'll see that baby and then they start realizing, oh, their older kiddo has some of these things going on, and they'll have memories come back about early days with their oldest, and we'll start to kind of make a plan for the older kiddo as well.
Got it. And I'll circle back on the feeding journey because I think it ties into something that we've um, identified that I know we want to talk about a little bit. But let's take a moment and just step back for a minute after reading on the website your path into this profession. You had kind of a personal journey, if I understand that correctly. And just would you mind sharing a little bit about that with everybody?
Yeah, of course. So I have my oldest is my stepson. And I met him when he was 15 months old, and I introduced him to lots of feeding and sensory things, and I had my therapist spin on things, and that was fun and part of my world. I was in early intervention for many years. So getting to know him and building a relationship with him was kind of an extension of that to a degree. Obviously, there's more levels to it. Building
Right.
a bond with a child that's part of your family, but
Sure.
bringing in some of my therapist tools and tricks. And then when I got pregnant with my daughter, I started venturing into the lactation world because I was like, oh, this will support me personally and professionally. And then when I had her, I had a home birth, and I loved my midwife, and it was just a crazy, wonderful ride, as any birth is. But she was born with ties, and I realized that I didn't know anything about newborns. I mean, I did on paper, but
Hmm.
even through all of my schooling, even through all of my trainings, even through my lactation courses, I knew about newborns, but I didn't know about newborns. I was not prepared um, in the ways that I wish I had been. And I
Hmm.
was very set on breastfeeding. I didn't introduce a
Okay.
passy or a bottle. Um,
Okay.
and I don't think we introduced a bottle until 5 or 6 weeks. I was definitely pushing it. And with that, she refused a bottle after weeks and weeks of really painful breastfeeding, but kind of grit and bear it. She was not efficient. She would feed all the time. And I was just
Mm.
like, okay, she's a high needs baby, you know? I didn't
Right.
know anything about ties. I didn't know anything about airway. I knew that she should sleep with her mouth closed, but that was about it. Um,
Okay.
I didn't know about like getting that tongue suction to the palate. I didn't know about true tongue mobility at all. Um, so we are here now at 6.5, and she still has ties and she's doing really well. But I didn't know all the things that I know now back then, and I wish I could go back.
Right.
So we have some long-term impact, but I've mitigated as well as I could. And there's a lot of just like bandwidth that goes along with that as far as therapizing your own child. Um, and same for my
Hmm.
stepson too. So there's things I wish we could do that just really aren't in the cards right now, and that's okay.
Yeah.
But we do the best we can. And I've definitely pulled my experiences from early days with both of them um, to ongoing learnings from where they are now with ties still intact and what that looks like in a 9 and 6 year old. And I kind of am able to bring that perspective of like, no, these are not emergent things. These are quality of life things that can make your
Right.
life so much better if we're
Hmm.
getting restful sleep and we're eating better foods and it's not a battle and all of those
Hmm.
things.
Right. Right. And a couple of things that you said that really are interesting, and I just want to point them out because it's something that we just hear over and over. One, as parents, we all wish we could go back. We all did the best we could. Here we are now. We know what we know now. All we can do is move forward. And
Exactly.
I've heard so many medical professionals come on here and say the same thing. I didn't know.
Mhm.
After all of your education and your training, it's just you didn't know.
It's wild to me thinking back about all of the time that I spent learning and how I didn't really even scratch the surface of what I needed
Mhm.
to know until my daughter was probably like 18 months old. So, and that's
That
with
is wild.
my background. And then we expect parents that are not in the medical field to have any clue about any of this is just
Right.
insane.
Yeah, exactly. Exactly. But that is part of our goal here is to educate parents. I mean, we're focused on medical professionals as well, but it's parents because we just didn't know. So, the more we share, the more we can get out there. Um, let's kind of pivot a little bit. You have a blog, and I'll anything that we mention here, I'll make sure we link in the show notes. But you have a blog post where you talk about body work. Um, And I found it pretty interesting. And one of the things that you talk about is that we're using it incorrectly. So I thought maybe we could talk a little bit, how are we supposed to be using this? And how does it apply specifically to children?
So bodywork is a big umbrella term that most manual therapists that are putting
Mhm.
hands on other people, will use, and it's kind of turned into this buzzword to a degree. Again, like
Okay.
along with holistic, there's lots of these buzzwords that parents hear and
Right.
are thrown around, but we don't have a true understanding of what they mean. So as a therapist, my understanding of body work is a passive manipulation.
Okay.
I am doing something to a body and hoping to get some sort of physiological response, either some lengthening or softening or some sort of tactile cue that something has happened.
Okay.
And then when we add in a therapeutic piece, it's a little bit more active. I'm demanding something of the body, whether that's a little bit more active range of motion of turning the head independently with the encouragement of a toy or mom's face or something like that, rather than me physically turning the head, is a
Okay.
good example. So
Got
body work
it.
and therapeutic movement go hand in hand. You do need both, but I think there can be a lapse in understanding when somebody is just doing body work. If you're just going to the chiropractor, if you're just going to the osteo, and it's not quote unquote sticking, you might need to add in some more therapeutic movement to make it active and have the body and the nervous system truly hold on to those adjustments.
Okay. And when you're doing body work, maybe, with an infant, when you're doing it, are we talking about tummy time and things that you would do with them in that kind of realm?
To a degree, yeah. So body work with an infant is, and infants don't have a lot of volitional movement, right? So we are moving
Right.
them a lot. There's a lot of hands-on manipulation. And then as they develop more strength and mobility, we're ensuring that that strength is developed through that new range of motion. So I talk about neck mobility a lot because that's a lot of what we're talking about with infants. We need to have good neck range of motion for
Mhm.
proper feeding and airway development. So when I think about body work for the neck and shoulders and decreasing tension there, we need to work through those layers of tension, but we also need to work on increasing strength in a balanced way to have balanced extension and flexion rather than the baby that is always in extension and arching back all of the time. So there's
Got
lots
it.
of different pieces.
Right. Right. So let's circle back now to more specifically the feeding journey that we touched on a little bit earlier. With regard to the feeding journey, let's just talk about tips and things for moms that are trying to breastfeed but are finding it difficult. And they know it's important because you've got to get that jaw exercise, you've got to get that jaw developed for this newborn. What kind of tips can you offer for parents?
I would say that bottle feeding kind of gets a bad rap. I really love to use bottle feeding to help enhance the breastfeeding relationship. So don't feel like you need to go all or nothing in your
Okay.
feeding journey, especially if that feels aligned to you. If you are like, no, I want to exclusively breastfeed, I don't really have a need to do a bottle, that's a great journey. I don't think it's most people's journey, unfortunately, just because we live in a capitalistic society.
Exactly, we've got to work.
Yep, exactly. So most of the time the goal is combo feeding, right? You're pumping while you're gone or supplementing, and then you're offering the breast or chest when you're with baby. But yeah, not having an all or nothing mentality around that and choosing bottles that are going to support your breastfeeding journey rather than potentially hinder it and get in the way.
What kind of bottles would you recommend?
Most bottles that are marketed as breastfeeding friendly, quote unquote, and they look more breast-like are going to encourage a really shallow latch and are more compression dominant. So we don't want compression at the breast, we want suction. And bottles that encourage suction and a wide latch would be Dr. Brown's, Even Flow, wide neck and standard neck. The Dr. Brown's wide neck, I would not recommend. That's a little bit more shallow.
Okay.
Yeah, and Lancino is a good one. I will say Lancino Slow Flow is not as slow as I would like. So the Pigeon Nipple, Pigeon S or SS, is the parent company of Lancino, and those are interchangeable with a lot of different bottles.
Okay.
Yeah.
Okay. And but these will at least or they say they simulate, I guess, the same kind of jaw movements that baby's going to get with mom, right? So you're still getting that exercise, and it's not going to throw a baby off between bottle and breast, right? I mean, are they usually able to transition pretty easily back and forth?
Typically, so usually if there's a strong preference for breast or bottle, it's just a sign of oral motor dysfunction. It's not necessarily that the bottle and the breast are too dissimilar. They're going to be different skills. The bottle, even the best bottle, even my favorite bottle, is going to require a different skill set than at the breast. Bottles don't change, right? They don't start out very firm and full of milk and then get softer as the feed goes on. The flow doesn't change. The mechanics don't have to shift slightly. So there's more nuance with breastfeeding that is hard to replicate. We can get really close to it, and we can still promote that wide latch that's going to help the jaw develop. But yeah, nothing can really replace the breast, unfortunately.
Right. So what are some signs that moms could look for, that maybe aren't working with? First of all, if you can work with a lactation specialist, we've said it before, go all in, take advantage of it. But if you can't, what are some signs you can look for that, things aren't right? I mean, you yourself said you pushed through the pain. That's what we thought we were supposed to do. This doesn't feel right. Let's just figure it out. We keep pushing, we get there. But obviously we now know that be a disservice to both mom and baby. What are some signs that they should look for that, hey, maybe we need some help? Maybe something's not quite right here.
Yeah. So pain is the biggest one, right? And that's the most obvious one. If your nipples are bleeding like mine were, it's a sign to go get help. Don't do what I did. We did get to a good place over time, but it took a long time, and I would not recommend that. So if we're looking at kind of like red flags, we are looking at open mouth breathing, right? Sleeping with their mouth open, having a milk tongue. It looks like a thrush tongue, but it really is just milk residue because the tongue isn't elevating to the palate and scraping off and kind of naturally cleaning. So that's a good sign that the tongue is low and not very high. If you have an idea of what you're looking for in baby's mouth, a high palate, it almost looks like a thumbprint on the roof of their mouth. It feels like they could put their thumb right in a little crevice on their palate. We want it to be almost like a shovel shape, like somebody put a spoon or a shovel in upside down and formed that palate. And it gets to be that way with the tongue elevated, but if the tongue is low, it doesn't form that way and it gets higher.
All right. And then obviously you work with babies, infants, younger children with tongue tie releases. What are some things that parents can look for, hey, I think my child might have a tongue tie? And then what do you recommend when they get released? What is the right kind of therapy? What should they be expecting for therapy, or at least therapy options?
Great questions. So I always recommend pre-op therapy, right? If we're even considering getting a release, but we're not quite sure, we're going to move forward with therapy as if we're trying to prevent the release almost. We're trying to get to a better place function-wise, where it seems like we might not even need that release. And then depending on where that baby is and timeline of the family, going back to work, just so many other factors that go into it. that's the ideal. And sometimes we can get to that in 2 to 3 weeks. Sometimes it takes a little longer. Just really depends on the baby. And then we'll have the release. And ideally, we're doing 6 weeks of post-op therapy.
Okay.
And that looks like 3 weeks of stretches. A lot of people will just call them stretches. And we're lifting the tongue up to keep that wound open. And there's different frequencies. People recommend different things in different parts of the country. Different providers will recommend slight variations, but most of the time it's 3 weeks of stretches. I'm a big fan, and I will preach to my clients that we do another 3 weeks, and not necessarily to the same intensity level by any means, but we are still doing on a weaning down process those lifts to keep the scar tissue nice and soft and supple and malleable to be able to get the tongue to fully elevate, and not just in the front, but in the back too. And we're doing more exercises to strengthen and tone the tongue to get the best result that we possibly can from that release, rather than just kind of relying on what the baby is going to do, because they're going to revert back to the mean. They're going to go back to what they feel is comfortable, and they're not going to help change the anatomy of that tongue. Yeah.
Got it. That's true. Yeah. So how do you, I mean, obviously you would work with every child is different. But when you're thinking about, to get the tongue all the way back, all the way up, how do stretches actually help that part of the process? It makes sense to me, because when we talk to people, and everybody else does it, I'm not the only one, practices with my tongue in the roof of my mouth when I'm talking to somebody. But how do you get the back when you're working with a child? How do you teach them to do the back part of that?
A lot of it is just different tactile cues, playing underneath the tongue. And I always say we're kind of creating safety with the sensation of the tongue leaving its parking spot in the back of the mouth. Like, we want it to be able to raise up and eventually get to a new parking spot on the palate, but it's going to take some time. So it feels anchored down in the back. And that's why a lot of times you'll see babies with just the front of their tongue suctioned up when we do that resting tongue posture hold. And it just takes some time to get the back of the tongue to get with the program and get up there as well.
So that goes back to, it can take weeks. Sometimes this is not a super fast process. And so these exercises that you send home, they're doing them at home for weeks, months?
Weeks at minimum. And I always kind of describe it as this ebb and flow of, sometimes we're heavy with the exercises. If we notice more drooling, if we notice some more regression, if we notice, something that clues us in that we could be doing better, right? If there's more milk loss while feeding, or clicking comes back, or something like that, we ramp up the exercises. But overall, they get less and less over time. And then if we hit a growth spurt, or we start teething really heavily, or something like that, there's new gradations of the exercises to kind of get the tongue moving in new ways and encourage that lingual suction as well.
Okay. And you mentioned drooling. I actually haven't heard somebody say that specifically before as a sign. Is that an oral dysfunction? Is that just a sign that the tongue isn't where it's supposed to be? What is drooling? How does that signal anything?
Depends on the age, right? So drooling in the newborn phase is not super common. That usually starts closer to like the 3 to 4 month mark, when hands start to get to the mouth and there's just more overflow because the tongue is moving more, and that's expected and really normal. Closer to like 6 to 9 months, when solids are introduced, you get a little bit more control of your fluids. So, some drooling, again, is normal, especially if they're congested and just like everything is kind of a mess. But hopefully that's an acute phase and not just how they are all the time. If they are, that can be lots of other things. But if we see consistent drooling past like 9-10 months, there's a sign that there could be some lower muscle tone in the mouth. It could be that the tongue needs some more input to be cued to swallow. So it might be a little
Okay.
bit of a sensory thing. And it could also go back to a tie and some restriction that it takes a lot of energy to get that swallow. So why would I do it to swallow saliva when that doesn't really give me anything? But I like to swallow milk, so I'll do that.
That makes sense. Makes sense.
Yeah.
So talking about oral dysfunction in the airway, I mean, obviously for us, it's in our everyday lives. We talk about it. That's all we talk about. But it's becoming more mainstream because of books like, you know, James Nestor's Breathe and Gasp and things like that. And you know, you're hearing it more in the medical profession as well. So as this moves more to the forefront and becomes something that, as first-time parents, you're going to be taught this now in your prenatal classes, and your doctors are going to talk to you about it. And how do you see your role as a holistic occupational therapist evolving and playing into this new, I say new healthcare paradigm, but this, you know, this new world?
I mean, I hope we get there. I sincerely hope that we get there. And
Yeah,
I
same.
yes, I'm optimistic and then also sometimes disheartened depending on which provider I've spoken with recently. But
Yeah,
I see myself as a little bit of a hub or a consultant for helping determine what makes the most sense to go for first. Do we need to see an ENT? Do we need to go for palatal expansion? Do we need to, you know, do the tongue tie? Do we need to, you know, what makes the most sense to do in which order, depending on the age of the child? And I think for the itty bitties, which is where I mostly focus for those newborns, I think hopefully every baby gets a feeding evaluation over time from a trained speech therapist or occupational therapist who really understands what's going on in the mouth and can look at the whole body and see how this baby is feeding with their body, because you learn so much. I only get in that baby's mouth at the end of an evaluation. I go through the whole body first before I even take a
really?
look in their mouth. Mm-hmm.
Wow. And why is that?
I can almost predict what that tie is going to look like. And sometimes I'm wrong, and I like to kind of play a game with myself. I'm like, am I going to be right this time? I don't know. And sometimes I'll let the families in on it. Like, okay, so I'm seeing like really tight fists. I think it's going to be, you know, XYZ. But there's so many other things that play into it. And I hope that every baby will get some level of body work and feeding evaluation from somebody who understands ties and understands oral function and isn't just going to throw a nipple shield at them and say, have a good day.
Right? Oh, the dream.
Mm-hmm.
That's what we're all kind of hoping for.
I know.
So at the end of every episode, I always like to hand it back to our guests. I mean, you are the experts, and just open the floor for anything that you want to share with parents, especially, but other medical providers. Anything we may not have covered, anything you want to emphasize, just you get the last word.
Thank you. I think the biggest thing is this, that it's never too late, right? We talked about how we just didn't know, and there's always something that you can do to be in a better place than where you were before and where you are now. Right? 1% better is kind of my mantra for everything, for myself and for my clients. Like, these little wins are big wins in this world.
Right? So take them. Absolutely.
Yep.
Well, thank you so much for being on the show today. I really, really appreciate it. And I know the information that you provided is going to be very useful to parents. So thank you.
Thank you so much for having me. This was wonderful. I really appreciate everything that you do in this part of the world. So
thank you.
Thank you.
Thank you.